Hi, everyone, and welcome to the April aEEG Coach Live Q&A call. I am super excited this morning to have with us Dr. Nidhi Shah from Packard Children's Hospital at Stanford University, and she will be presenting to us some of her research. And she is, like most of you fellows out there, post-call and agreed to do this talk today. So I'm really grateful. It's been great working with Nidhi on several aEEG projects. She's really becoming a leader in this area, and especially in the use of aEEG during the perioperative period. So I'm really excited that she's willing to share some of her findings as well as some of her research with us. And without further ado, I'll just allow Nidhi to take over.
Thanks so much, Kathy. Good morning or good afternoon to everyone on this call or on the recording if that's when you're listening. As Kathy said, my name is Nidhi. I'm one of the fellows here at Stanford University, and I am really excited about some of the work that has been done looking at the effects of anesthesia on aEEG, and so that's what we'll be talking about a little bit today. I will be presenting some of my preliminary data. So why don't we start right into it, and if there's any questions at any point, people can chime in. So to provide a little bit of background, we know that neonates in the intensive care unit here and everywhere are really at risk for neurodevelopmental impairment. Synaptogenesis, we know, begins really in the third trimester and continues for 2 to 3 years postnatally. And so really the time that the infants are in the NICU is a critical period. There's been several studies looking at infants undergoing surgery, and what they've shown is that infants undergoing surgery are at higher risk for neurodevelopmental impairment. In a study done by Morris et al., very low birth weight infants who were undergoing major surgery had an increased risk of death or neurodevelopmental impairment by 50%. And in another study done here at Stanford, Susan Hintz found that those infants who had surgery for necrotizing enterocolitis, or NEC, had a higher risk for neurodevelopmental impairment compared to their counterparts that were just either medically treated or didn't have necrotizing enterocolitis. Therefore, undergoing surgery is sort of an independent risk factor for infants with neurodevelopmental impairment. So that's sort of the surgical aspect of it. The other sort of component that we often look at as well is the anesthetic component of it. And I think this is the part of the area that we don't really think that much as about. So there's been a lot of studies in animal models looking at the effects of some of the common anesthetic agents and sort of what happens in the developing brain. So in some of the animal models, what they found was common agents that we see in the NICU, propofol, ketamine, and isoflurane, they actually induce neural apoptosis in animal models. And when you follow these animal models long term, what they saw was cognitive deficits and behavioral changes as well in those animals exposed to general anesthesia compared to their counterparts. Because in humans we can't actually do sort of a randomized control trial of that, sibling studies are sort of the next best study. And what they found is in siblings that were exposed to general anesthesia, they had higher rates of developmental and behavioral diagnoses compared to their siblings that were not exposed to general anesthesia. Again, not a perfect study, but it does show us that perhaps anesthesia does have more significant effects than we think about. So here at Stanford, one of my studies is looking at the effects of aEEG, and this was done partially in response to some of the papers that came out looking at specific changes in aEEG in cardiac patients. So these are some of the hypoplast babies. They noted that in a third of their patients that had undergone surgery for things like or Norwood, they noticed a third of those patients had periop seizures that were only noted on aEEG, not clinically. They also found that aEEG was also sort of predictive of short-term and long-term neurodevelopmental outcomes. So failure of the aEEG to recover by 48 hours postoperatively was associated with worse neurodevelopmental outcomes at 2 years. And failure of the aEEG to recover by 7 days was actually associated with higher mortality. So I wanted to then extend this into our NICU population. And so what I've done is I've actually looked at sort of aEEG changes in some of the patients in the NICU that are undergoing surgery for a variety of reasons. So this is just one of my sample tracings for a patient that was undergoing a G2 placement. And what you can see at the top is sort of the medications, the anesthesia that was used, and the timing of that in relation to the EEG. So the patient was initially induced again with propofol, rocuronium, and fentanyl, and had a continuous tracing at baseline. As the sevoflurane was turned on, you can see that the tracing goes from a continuous to a discontinuous pattern, and eventually down to even a burst suppression pattern as the sevoflurane dose is increased. Gets all the way down to a low voltage pattern where it stays for the maintenance of the case. And as the sevoflurane is turned off, you can see that the aEEG nicely recovers to a continuous pattern. To me, this is just one of the sort of more striking aEEG tracings that show the clear effect of anesthesia on our patient population. In this patient particularly, the effect was brief, but in our next patient, the effect wasn't as brief. So this is a patient that had an emergent CPAM resection or resection of a mass in the lungs. And this was a sick 36-weeker. So you can see that his baseline started off again in a discontinuous pattern. He was induced with rocuronium, which didn't seem like it made much of a difference in his aEEG. But as soon as he got the ketamine, you can see that his aEEG went from a discontinuous pattern to basically a flat tracing pattern. Even after the surgery was done, when he was transported back to the NICU, you can see that the changes in his aEEG persisted for quite some time. It took this patient almost 24 hours to recover from his anesthetic exposure. So looking at this, these are two examples of the 40 plus babies that I've enrolled so far, and I'm going to aggregate my data and hopefully write that up soon. But it's something that I want people to be aware of. And as you are advocating for your patients in the NICU, I think that what I would recommend is advocating for patients undergoing regional anesthesia for things like G2 placement or minor surgeries. It is possible to undergo sort of either caudal block or regional anesthesia. I think that there's a great deal of advantage in using that, knowing that general anesthesia is potentially harmful to our patients. I think it's also worthwhile to try to combine procedures if possible to try to minimize the number of exposures to general anesthesia. And then perhaps most importantly is to consider post-op monitoring with aEEG in infants that are at high risk. So I look forward to sharing my data with you guys as it comes out. And at this point, I'll turn it over and take any questions from anyone.
Thank you, Nidhi, so much. That was awesome. I love that review, and I think that your pictures are amazing. And I think I saw Gabriel post here too. Nice picture. We all love those really striking aEEG changes, and I think your point is so well taken about just this, considering this post-op monitoring and just seeing, again, we have this opportunity to see inside literally about what's happening and really taking advantage of this tool that maybe is sitting in the closet for many people in their NICU, and they don't think about using it in these patient populations.
Absolutely. I think that it is. I've seen a lot of parents asking me about it as well, sort of saying, when is my baby going to wake up? And I'd be interested to see if this ever, also correlates from that perspective too. So I think that there's a lot of interesting questions that we can ask using aEEG in this peri-op period.
Yeah. So, Gabriel, if you have any questions, feel free, please, to type them in there. Yeah, he's just agreeing with everything you're saying there.
Thanks, Gabriel.
So maybe just a couple questions I have, knowing that creating this particular research project has had its challenges. So what would be your kind of biggest takeaways? What would you maybe advise someone differently than what from your design? Would you maybe tell a little bit about kind of how you organize like the period for monitoring, and then maybe some of the challenges of things you've had to work through, so people might think about that as they consider this?
Sure. So what my research design is, I am enrolling patients and establishing a baseline for them. So at least 6 hours of pre-operative monitoring. I really want to get a sense of what their normal background activity is before any exposure to anesthesia. Look at sort of their sleep-wake cycles to see how long it takes to recover those sleep-wake cycles. So at least 6 hours preoperatively. I'm monitoring intra-op as well, so I sit down in the majority of these surgeries to make sure the leads stay on and that the tracings are quality tracings. And then I'm monitoring for up to 72 hours afterwards. By 72 hours, the majority of the AEGs have recovered in my sort of prelim analysis, but that's the data design that I've done so far. Some of the trouble that I've had, I think, is with standardizing sort of the patient population and also the anesthetic regimen at this point because of sort of enrollment criteria and trying to maximize the number of enrollees that I actually get. I'm taking a majority of kids that come through the NICU, and so that includes preemies and term kiddos, patients that are undergoing simple surgeries like G-tubes versus complex surgeries like CDH repairs. So I think that is one thing that ideally I would be able to control for, and it's something that I'm going to try to control for in my actually analysis. But if there's a way to have a more uniform population, I think that would lend strength to anybody's study. In addition, I think that standardizing anesthetic regimens would also be ideal. From my, again, experience, it's been a cocktail of anesthesia, which can mean up to 10 or 14 different agents being used. And so to know that one particular anesthetic has this effect on the aEEG, I think is a little bit, it's too premature to say that because most likely it's a cocktail being used. So I would recommend if there's a way that you can talk to your anesthesiologist about standardizing the cocktail that they're using, say for a G-tube repair or a G-tube placement or a hernia repair, I think that would actually lend a lot of strength to the study, and that is actually something that I would like to proceed as my secondary study as well.
That's really great. Yeah, you don't even really think about how those kind of just typical variances in clinical practice can really make a difference when you're looking at something else from a research point of view. So that's that's actually a really good insight to think about as well. I think some of the other questions that kind of popped to mind when you were speaking were, let's see. Oh, there's actually a question from Gabriel, so maybe we'll take that. Do you think that aEEG might have more interesting measures than BIS during the intra-op period?
So I've talked to several of the anesthesiologists about the BIS because I know that there has been some work done with that in terms of looking at the level of sedation and the depth of anesthesia essentially. And at least in the United States from the anesthesia doctors that I've talked to, there isn't a lot of buy-in in the BIS. And the other thing that is sort of a little bit more cumbersome about the BIS is it's actually a bigger machine. It's more complicated to sort of put on. And so I think from a practical standpoint, the aEEG is much more user-friendly. I think for, say, the nurses putting it on, for me to read it at the bedside since I don't have experience interpreting the BIS necessarily. And so I think that from a neonatology world, aEEG seems to be something that we're more familiar with, and I think that it's more readily understandable. And I think that the BIS has sort of fallen out of favor, at least with the anesthesiologists that I've worked with here. So I think that from that practical standpoint, I think it is a better tool, but it's not, again, it's just a screening tool, so it doesn't capture everything. So I could be missing sort of deeper seizures or very brief seizures. The aEEG wouldn't necessarily capture that. So I think you sort of have to do what you can to optimize your results. And I think for us, the aEEG was the right tool for that.
Well, I think one of the nice things about the way you designed your study is that it takes a lot of burden off of any kind of peri-op or intra-op procedural things that they would have to do to actually acquire the signal. So you actually putting the aEEG on before they leave the NICU and basically just, coaching them through how to maintain a decent signal, really has made it relatively painless on them. And I know you've had some technical challenges, like mechanical challenges with people unplugging the device and those kinds of things. But I think at least by putting the aEEG on in the NICU, you at least minimize their workload for acquiring the signal.
Correct. And there's a lot more buy-in when they don't have to do anything for it. It is literally just parked in the corner. And so you get a little bit more buy-in from anesthesia at that standpoint.
Yeah, yeah, absolutely. Any other questions related to Dr. Shah's presentation? And if not, we can kind of just go to any kind of open forum or general questions. So thank you to all of you who joined today. And then, of course, to all of you out there who watched the recording. It was a little bit of a crazy week for me, so sorry for the change in date and time, but it ended up that Nidhi and I could work it out together. So that was what we wanted to do. So anyways, well, I'm just going to give a quick couple announcements. Probably if you are on my newsletter list, you saw that we're going to be starting the online aEEG course. It's going to begin on June the 8th. I know some of you have already taken the course before, and we'll be reaching out to you with some information about how you can join this one as well. But basically, it's going to be an 8-week online course, and we're going to have sessions similar to this where we're going to have a particular focus and dive a little bit deeper into a particular topic of aEEG. And then we will be having those available for you to watch for up to 1 year. And to validate your learning, we're going to be having some quick post-tests, just basically about those modules. And then we'll have 2 specific Q&A calls. We're going to have a private Facebook group as well as our ongoing community area in the forum for people who are involved in the course. So if you have any questions, as always, please reach out to me. And they are going to be, I believe, Gabriel, 8 a.m. on Mondays. And so it will correspond to the time, at least 8 a.m. Pacific time on Mondays for the 8 weeks starting June the 8th. And of course, the recordings will be available shortly after that day and then available for the 1 year after. Anyway, so I invite you, if you have any questions, I'd love to have you on our course. And again, just a huge thank you to Dr. Nidhi Shah for getting on this morning and sharing just her research and her experience and just the practical use of aEEG in a very real situation with some pretty real risks. So again, thank you, Nidhi, and thank you to all of you who joined us.
Pleasure. Thank you, Kathy.
All right, take care, and I will see you guys all online later. Or in person.